The following is a paid program, and the views expressed do not necessarily represent the opinions of the management of this station or Hamel Broadcasting.
This is 1 in 31, a presentation from Anderson Center for Autism. 1 in 31 is a weekly show devoted to autism spectrum disorder.
Good morning and welcome to 1 in 31, the weekly talk show on topics related to autism spectrum disorder. I'm your host, Eliza Bozensky, Chief Development Officer at Anderson Center for Autism. And today I'm talking with Dr. Alex Kolevzon, who is, among many other things, the Clinical Director of the Seaver Autism Center and the Icahn School of Medicine at Mount Sinai. You're a professor, you're a director, and you're going to talk us through this big topic, which is actually also the name of this podcast. But the CDC study that comes out periodically with updated information as to how many children in this particular CDC ongoing study are diagnosed with autism. So Dr. Kolevzon, thank you so much for being on the show.
Thank you. It's good to be here.
Great. So I always love to have somebody who's more knowledgeable than I, for sure, about this particular study and about how we in this country, those of us involved in research and working with individuals with autism and families and any aspect of the community are looking at this number. And if you go back to the beginning of this podcast, when I first started hosting it several years back, it was called 1 in 88. And that is because at that time, the CDC statistics were saying that 1 out of every 88 children in this particular study in this country were diagnosed on the autism spectrum. Over the years, I have had to change the name of this show multiple times because I wanted to change it every time the new statistic came out, again, following this long-term study. Very recently, we are now at 1 in 31. So there's conjecture all over the map. I'm sure you've heard it. I'm sure you've maybe been part of those discussions in any number of ways about why and how and I like to always have a guest on to talk when this changes about just your thoughts. What are the facts? What's the research showing? What are the trends and what are your thoughts about it? So now I'd love for you to take a few minutes and introduce yourself. Tell us about your background and how you've gotten to be where you are in the field, and then we'll get into the study.
Okay, so I guess I can begin by saying that when I first started thinking about autism, it was 1 out of 150.
Yeah.
It was a campaign 1 out of 150. Although when Leo Connor first described the condition, it was something like 1 out of 1,000. Mm-hmm. Over time, of course, the diagnostic criteria have changed dramatically. Mm-hmm. But before launching into that, so I was a camp counselor in 1990. I was in college. I got to be a camp counselor for a kid with autism. It fascinated me. And one of the things that was so fascinating was how this child had such profound strengths, but at the same time was so impaired. The other thing that fascinated me was that there were, I think, 12 other kids in the bunk, all of whom carried the diagnosis of autism and all of whom were so dramatically different. Mm-hmm. That's kind of what's going on here, is that we keep changing the criteria. We keep broadening the criteria. When you described 1 out of 88, we were probably back in the DSM-3. We're now in the DSM-5, the Diagnostic and Statistical Manual. Right. The way that we identify children has changed dramatically. So I think that's a big driver. At the same time, I think we're doing a much better job of identifying people. I mean, it used to be that they weren't until 5 or 6 years old that people would be reliably identified. Now, and since 2007, frankly, the American Academy of Pediatrics mandates that kids should be screened at 18 months and 24 months. Previously weren't identified, and now they are identified. So that's a good thing.
Yeah.
I think that there's also been a major shift in the culture where I remember when I first started, nobody wanted the diagnosis because it felt, scary, almost like a life sentence of sorts. And now it's become a very clear path to really appropriate services: speech therapy, occupational therapy, physical therapy, behavioral therapies. And so I think what's happened is that people will almost seek out the diagnosis as a way to get access to needed services. But because you've got language delays and because you've got some behavioral issues and because you've got some social impairment, that doesn't necessarily mean that you have autism.
Right.
That you may benefit from some of the treatment. So, I'm not suggesting that people are getting inappropriate treatments. I'm suggesting, though, that they are getting diagnoses in order to justify the treatments. So that's another big factor. Then now, of course, there's insurance mandates that say you actually have to provide the treatment, reimburse the treatment that is, but only if you have a certain label, right? And that label is autism. So it's pushed a lot of people into this category.
Interesting. Okay. Yeah, I mean, everything you're saying resonates with me. And I work at Anderson Center for Autism, where we are not conducting, massive amounts of research. We're not looking actually at the why so much as directly serving children and adults with autism, but doing a lot of interaction and talking with both professional providers of care, but also families. So I would say definitely amongst your whole list of things that you just put out there, the shift in culture and the shift in parents both maybe recognizing earlier on that something might be worth, asking a pediatrician to look at, and being more aware of some of the signs that might be very early. But also the pathway towards services. And just, I think another good thing that we've seen is the beginning anyway of a reduction in the stigma attached to not just the individual with autism, but their family, the siblings, the parents who are taking them out in the community. The idea that it was so hard and still is for many people, very hard to be engaged with, your community in terms of restaurants and shopping and recreational activities and even school sometimes, because of just not feeling welcome and feeling more safe while staying, inside and kind of in your own home and very isolated. So I think combining that maybe with the fact that doctors are given more tools, more training, those mandates, like you said, it's kind of like it seems to be sort of a connection of all these aligning planets, if you will, that are starting to come together. But you added something that I hadn't heard before, and it's interesting, the idea that insurance companies are requiring a certain label. And so are we now, what do we do with the fact that now we've got therapies and services that can help somebody who doesn't have the label, but they're being told, or their caregivers are being told, that they have to have the label in order to get those services? Something seems off there.
Well, yeah, I don't think we're going to solve the broken healthcare system in this conversation, but there's lots of examples of that. I mean, even prior to 1990, I think the Individuals with Disabilities Act didn't provide a guarantee for special education services for kids with autism. If you had an intellectual disability, you got those services, but you didn't necessarily get special ed if you had autism. And then after 1990, autism, or I think 1991, autism got included. And so what happened was there was a shift of kids being diagnosed previously with intellectual disability who now got diagnosed with autism, but it's the same group of kids. So these kinds of cultural, regulatory factors are major, major drivers.
Yeah.
The other thing we didn't mention was sort of rigor in the studies, because you talked about the 1 out of 31 statistic. That's driven by the CDC. The CDC is monitoring, many states, 13 states now, I think it's up to 15 states, but they're looking at school records and they're looking at pediatric records. They're not actually directly evaluating children. There's no observational assessment, which is, of course, the gold standard. And as a result, there's absolutely no question that those rates are highly inflated just based on the methods of the study.
Right. And it's tricky. I remember years ago during one of the changes in the number, maybe the first one after I started the podcast, I was able to interview one of the scientists who's involved directly in the CDC study. Yeah. And he was really great. I will not try to recreate what he said, but he was willing to explain on the show and during the interview how the study is conducted. But there is a significant difference between something that's looking at, because some studies look at just records, written records from, medical records and school records. Some look at kind of teacher report forms and parent written response forms, right? Surveys. And then some, like you said, the gold standard is actual observing each child. So I guess, I don't know, where's the question? The question, I guess, would be, are there studies out there that we as the general public or parent or other service providers like Anderson should also be looking at, that you were aware of, that you think are really kind of next level in terms of bringing us into the future of better understanding where we are?
I think doing very large population-based epidemiological studies is very, very challenging without like a birth registry that you'll have in Denmark or Sweden or Israel, for example. One study that I think about is, I think it was out of Atlanta. This is probably 10 years ago, where they actually went and did observational assessments of kids that were identified as having autism according to the CDC methods. And in that study alone, when they did the kind of gold standard approach, I think at least 20% of those kids did not meet criteria for autism. So there's absolutely no question that there's a clear overdiagnosis going on.
Interesting. Okay, but I agree with you. I mean, that's very hard to do, large scale. I mean, you can't roll that out across a country. I couldn't imagine.
No, it's very well. I mean, you can if you have a birth registry. If everyone that's sort of born is registered and all their health data are uploaded, that's challenging to do, especially in our system. Another good example of a well-done study was back in the early 2000s, where they were asking the question, was there a true increase in the incidence? Were there new cases being born? So this was a group that went through, I think it was called the Stafford region in the UK. And they actually identified, I think, 15,000 different households that had some developmental delay. And those who had delays, they did these gold standard assessments and came up with the number of, I think, about 1 out of 100 or so. Can't remember exactly the statistic, but the important part of the study was they went then and did a subsequent study using a birth cohort that was born a couple of years later. Because the idea is if you had a true increase in the incidence, if more cases were being born, you should see the prevalence go up. And it did. It was exactly the same prevalence.
Interesting.
Yeah.
And how long ago was that? Do you know?
This was, I think, 2003, 2004-ish, 2005. Yeah. Shocker Barbie, the first author. Do you guys have show notes? We can put it in the show notes.
Yeah, you can send those to Melanie. We can put those in. Absolutely. The links. Yeah. I think this is really fascinating because, again, the CDC study is like this big one that gets so much attention, but I appreciate this because it's important also that we disseminate whenever we can information for people who wish to look further and deeper. And there is a lot, I think, I know we get asked all the time, are the numbers different in different countries? And if so, why? And I know enough to say the studies are not comparable. You can't take one thing, this and say, well, it's a different number over here. And that all means exactly the same thing. You have to really get into each study to see what they're looking at and what their methods are. Beyond that, that's kind of the scope of what I can offer. So we're going to take a short break. When we come back, though, I have another question for you that's brewing in my mind. So we'll stay tuned for that. This is 1 in 31, the weekly talk show on topics related to autism spectrum disorder. I'm your host, Eliza Bozensky, and we'll be right back.
I'm Angela Bassett. As a first responder on screen, I know what it means to act fast in an emergency. In real life, the same urgency can save lives, especially when it comes to food allergy. For 33 million Americans, one bite can cause a life-threatening reaction. Now, there's a needle-free option, a new way to carry epinephrine. Know the risk, know the options. Be ready to act. Learn more at foodallergy.org/ready to act.
And now 1 in 31 continues on 100.7 WHUD. This is a weekly community affairs presentation from the Anderson Center for Autism.
Welcome back to 1 in 31, the weekly talk show on topics related to autism spectrum disorder. I'm your host, Eliza Bozensky, and I'm talking with Dr. Alex Kolevzon. I keep saying your name wrong. I'm sorry. I asked to.
Kolevzon, like olive.
Kolevzon. Dr. Kolevzon is with the Seaver Autism Center and also Mount Sinai, and is here as our expert guest talking about the recent change in the 1 in 31 number, the name of this podcast from the CDC study. But we've recently just gotten into some other studies that are very different and worth looking at. So we'll do our best to get some links out there when we post this this interview, so people can check that out to get more information. In your intro, you talked about your experience as a camp director in 1990, and it's interesting.
Camp counselor.
Yeah. Camp counselor, exactly. You and I must be somewhere around the same age because that sounds about right to me too. But I was a teacher after that, a few years after that, in one of my early jobs, and the very first person I ever met with autism was a student in my class. I worked in a private school, a very small school, and he was a kid who had been diagnosed and was attending this private school because he benefited from small class size, and he's all grown up now and living a great life, which is wonderful to hear. But similar to you, where you kind of talked about how you had this one camper with autism, and then you had this this cottage, I think you said with multiple kids with autism, but all different people. That really also resonated with me because you underscored something that I think, especially when we're talking about research and science, is really important to remember, that each of these people is a person and a unique individual whose autism may or may not manifest in a similar way to the person next to them, or even a sibling who might also be on the spectrum, or fellow campers, fellow students. So when, like you and I, when we were introduced to a young person that we may not have been expecting to meet, and you start, then that's kind of your first lesson, is like, this is a person first, and they have autism, and it's kind of interesting and engaging for me. I think it brings us into the field in a unique way. You combine that statement, or you then went into the fact that we keep broadening the criteria with all of the iterations of the DSM. And so I wonder if we could talk a little bit about the combination of those two things. We've got individual people who all are different and unique and wonderful in their own way. And then you've got an ever-changing criteria of diagnosis in the DSM. And how do you think that's impacting really any research, not just the CDC research, but I would think that has an impact pretty much everywhere, maybe with the exception of the gold standard of direct observation, because then you're seeing every individual person directly. But like, where do you put that when you're working on research and you're writing up your results? Is that an asterisk somewhere that, hey, keep in mind, these are all unique individual people? How do you make sure that stays prevalent or, top of mind in some way?
So the main goal of the Seaver Autism Center is to develop new treatments. And that's kind of why I got into this field in the first place. This is back in the early 2000s. And the point that you make is exactly the challenge that we faced, where you're trying to develop a new treatment and you're taking 10, 20, 50 kids and applying a single treatment in some sort of controlled study. And all those kids are so profoundly different, both clinically and biologically. It's very hard to show improvement, right? And so we've always known in the scientific community that autism is primarily genetic in origin. This goes back to studies from the 1970s, twin studies. And so in the last 15 or so years, the approach has been more to focus on the biology, taking what's called a genetics first approach. And so my shift in my way of addressing this issue in terms of research is to think about specific genetic forms of autism and to actually focus on more profound forms of autism. So these are kids that are more intellectually disabled, they're more verbally impaired, that they have major deficits in their activities of daily living and their adaptive functioning. And so that's been the way that we've kind of approached it.
So your way of dealing with that factor, which is an important and really wonderful factor, is to go specific, to say, I'm looking at this one particular aspect to study.
Yeah, if you're studying something, whether it's a clinical feature or whether it's the response to treatment, if the treatment is biologically based, there's a major advantage to addressing it in a group of people who have at least some similar underlying biology. And in this case, it means a specific gene that's changed in a way that affects the function of the protein that gene transcribes for.
Okay. Again, with my limited level of really experience in that area, very limited, that makes sense to me. Long term, so well beyond maybe the studies that you're involved in today, what is it? I'm not asking you to speak on behalf of every researcher everywhere, but in terms of looking for new treatments, is there a general common goal that the professionals in that field are hoping to see? Obviously, I would think it has to do with something beneficial that hasn't been seen before, hasn't been used before. But is it also combined with less intrusive or non-chemical, or is it just whatever works? I'm just curious. I have no idea.
In general, when you're trying to develop treatments, the standard is that you need to improve the way the person feels or functions or survives. And that can mean a lot of different things to a lot of different people. We just mentioned how different all these folks are. So somebody could be profoundly affected by sensory sensitivities, for example, and that could have a huge impact on how they interact with their environment. And so a major goal for them would be to reduce their sensory sensitivities, but somebody else may not have any sensory sensitivities at all. They may be really language impaired and you want to focus for them on their language.
Yeah.
So it's a very complicated area. And in some ways, the broadening of the criteria and the kind of heterogeneity poses a real challenge in that sense, which is, as I said, why we try to focus on things that are common across the groups.
Yeah.
Another example is the one thing that we know affects all kids with autism, by definition, is some sort of social communication impairment. So that's a
Hmm.
common thread. I mean, the idea of trying to improve ways of communicating, whatever that means to somebody, that's definitely a common goal, and that's going to always be a goal, because I don't think there's going to be a time when our criteria gets so diluted that it no longer means a social communication impairment. I think that's always going to be the core of autism.
Yeah, that makes sense as well. It makes me think of I've working at Anderson for about 20 years, and one of the things that I got to sort of be there for during that time was the evolution of our mission statement, which is to optimize the quality of life for individuals with autism.
Yeah.
And I remember the many, many, many discussions that were had and continue to be had about um, how does one define someone else's quality of life? And really the answer was you can't, because of what you just said. It's so unique to that person that even a close family member, a parent, a caregiver, a sibling might not get it perfect because it's unique to that own individual. And then, when you bring in the population that we serve at Anderson, which sounds similar to the population that you might be looking at in your work, which is really profoundly affected individuals who often are non-vocal or minimally vocal, sensory sensitivities, behaviorally complex, and really in need of quite a lot of sort of one-on-one care, throughout the lifespan. It becomes very convoluted. And so one of the things that we worked on, just to try to do our due diligence when you're putting out a mission statement like that, was to work with some colleagues to identify any types of scales that are out there that allow for the rating of one's quality of life. So I just put that out there to you because I think, to me, it takes all of this work coming together in some way and like all of this cross-pollination to really be able to measure the success of a possible treatment connected to what you can observe, obviously the gold standard, and also having sort of that idealistic goal of, but I believe it's reachable. I'm an idealist and an optimist, of really having a positive impact on somebody's quality of life. Because if you can do that, then the other beautiful thing that happens is that if you're in that work, I think you optimize your own quality of life by nature of being involved in that type of impactful work, with other people. So I don't know. We don't have much time left, but I just want to give you a chance to, that's kind of my thought about this conversation is it's so big. But I'm so pleased to know that people like you are working in the field and are willing to come on this podcast and talk about it. Do you have any other parting sort of thoughts about next steps in your work or where you think it's leading, what you think the next number might be the next time the study comes out?
So I'll say a couple of things. One, I agree with you about quality of life. Quality of life means different things to different people. And it's not just about the affected person. It's about the family. It's about the siblings. It's about parents. I mean, you can make very, very small changes that have a huge impact on quality of life. So I think that's always important to keep in mind. Going back to the topic of our discussion, really, this 1 out of 31 situation, I think there's a big risk when we start to broaden the criteria so much and end up diagnosing people with autism who don't have autism when it comes to developing treatments and trying to improve quality of life. Because when it starts to mean so many different things, it really starts to lose its meaning. And that gets me a little bit concerned. And I think on one hand, while it's been important to reduce some of the stigma and to accept the neurodiversity, it's also been a little bit problematic in the sense that it's triggered this fear of an epidemic of autism, which I don't think we're seeing at all. And so it's a very important line to try to toe. So the answer to your last question is what's going to happen in the future, what our next number is going to be. I'm also an optimist, and I believe in science. And I think that what's going to happen is likely things are going to start to correct. And we're going to go back to seeing things kind of more aligned with what the actual prevalence is. Probably about 1 out of 100 if I had to take an educated guess at it.
Okay. Well, I love talking to fellow optimists, and I really do appreciate the knowledge and the expertise that you shared today, and helped us reintroduce this podcast as 1 in 31 now, and we'll see what happens. I really do appreciate all that you're doing in the field, and thank you for answering my questions and having this discussion.
My pleasure.
This is 1 in 31, the weekly podcast on topics related to autism spectrum disorder. I'm your host, Eliza Bozensky, and remember, Anderson cares.
You've been listening to 1 in 31, a weekly presentation from Anderson Center for Autism. Join them for another edition of the show next weekend.